Welcome to EADV Live. Today's topic, network meta-analysis and dermatology. On behalf of the EADV, we welcome you to today's interactive webcast. If you have questions or comments about the subject matter, send them in at any time during the presentation, and our speakers will do their best to address them at the end. If you're a member and accessing this webcast from the platform, write your questions in the comments section on the right side of the screen. If you're viewing this webcast from social media, just put your questions in the chat or comment box. Today, we are happy to hand over the webcast to EADV Epidemiology Task Force member, Professor Emilie Sbidian. Professor, thank you.
Thank you very much. So good afternoon, everyone, and welcome to this new EADV webinar dedicated to the usefulness of systematic reviews and meta-analysis for systemic treatments for psoriasis. So my name is Emilie Sbidian. I'm working as a dermatologist at Henri Mondor Hospital in Créteil, France. And this session, I will share this session with Dr. Robin Guelimi, who is also a dermatologist at the same department, and Dr. Laurence Le Cleach, also a dermatologist and the head of the French satellite of the Cochrane Skin Group. So we will start this session with Dr. Robin Guelimi, network meta-analyses, methodological points for readers, authors, and reviewers. Then we will move to the presentation by Laurence Le Cleach of the main result of the Living Cochrane Network meta-analysis for psoriasis. And at the last part, it will be my pleasure to discuss the limits of such methodology. So before we start, please switch your microphone to mute. And at the end of the presentation, you could submit any question you may have by the chat on YouTube, and we'll do our best to answer any queries. Thank you again for joining us, and please, Robin, it is your first part.
Thank you very much. So to start this presentation, I will start by going through some methodological points for readers, authors, and reviewers regarding network meta-analysis. To start, some definitions. What is a network meta-analysis? So network meta-analysis is a relatively recent statistical method that allows to compare several treatments in a single analysis by combining both direct and indirect evidence. Direct evidence are extracted data directly from trials comparing a treatment A to a treatment B, while indirect evidence, on the other hand, are mathematically deduced when two or more interventions have been compared to a common comparator. Network meta-analysis allows to determine the measures of the relative effects between two interventions, including the ones that have never been compared in studies or trials. Network meta-analysis also allows an estimation of the ranking of the included interventions regarding some specific outcomes. Network meta-analyses have gained an incredible popularity in comparativeness effectiveness research. However, their validity depends on several assumptions and considerations that we are going to see in this presentation. So what should we look at first? We have to remember that network meta-analysis comes after a systematic review and a classical meta-analysis. Therefore, they should follow the same standards as those two steps. First of all, these elements that we are going to describe should be in every author's plan when conducting a network meta-analysis. Also, those elements will be important for the grading of the certainty of the evidence. Among those elements, we have the definition of a precise research question that needs to be relevant both to the researcher and the patients. Also, we have to clearly define the inclusion criteria, which are the population of interest, the intervention and comparator that are going to be included in the study, and the outcome of interest. We also have to do a thorough systematic review to include every available evidence that will be helpful to answer the research question. To do so, we need to go through several databases using a validated and large search equation, and also make sure to seek as well as published and unpublished studies. Authors should also evaluate the risk of bias of the included studies. They should provide a comprehensive and transparent presentation of the result and also register a protocol prior to the conduct of the study that will figure every step of the systematic review, the meta-analysis, and the network meta-analysis. So we said that network meta-analysis had some assumptions that needed to be checked to ensure their validity. One of those assumptions is the transitivity assumption, which is a necessary assumption that authors need to check. So the transitivity assumption is the assumption under which it is valid to combine both direct and indirect evidence. To do so, authors must make sure that there are no major differences regarding the important factors that may affect this outcome. There are several methods that can be used. For example, author can choose inclusion criteria that make this assumption plausible. Also, they can check for the distribution of known effect modifier across the different comparison. On the right, you see a figure where there is a representation of the distribution of age across different comparisons that can help authors to evaluate the plausibility of the transitivity assumption. Another key assumption is the coherence assumption. Coherence is the agreement between direct and indirect evidence, and it is the statistical manifestation of transitivity. When the different sources of evidence, which are direct and indirect evidence, disagree, we talk about incoherence. Incoherence can be evaluated both locally and globally in the network using different methods. Authors should check for the coherence assumption in their network, and in case of incoherence, they may explore it using meta-regression or subgroup analysis to identify potential sources of incoherence. Heterogeneity. Heterogeneity is the underlying differences between the studies that directly compare the same pair of intervention. Heterogeneity can be clinical, methodological, or statistical. Statistical heterogeneity manifests itself in the observed interventions effect being more different from each other than one could expect due only to chance. In case of high heterogeneity, this can lower the certainty of the evidence derived from the meta-analysis and the network meta-analysis. Authors must thus evaluate the heterogeneity within each direct comparison, which are the guidelines known for standard pairwise meta-analysis, but they should also evaluate the heterogeneity in the entire network. In case of heterogeneity, it must be addressed and explored using subgroup analysis and meta-regression when possible. After the network meta-analysis, authors should focus on the presentation of their methods and their results. The presentation should follow the PRISMA statement, and more importantly, the PRISMA NMA, which is an extension statement for the reporting of systematic reviews incorporating network meta-analysis. And among the items that are recommended are a presentation of the network structure and geometry, an evaluation of the risk of bias of the included studies, the result of the individual studies, and also, of course, the synthesis of the results. A clear presentation of the results and the findings is paramount, but can be sometimes challenging to produce, especially when the network is large. Again, several methods and graphical representation exist to help authors provide a clear and visual representation of their finding. On the left, you can see a forest plot where is represented the treatment effect with their confidence interval relative to a common comparator, which is here placebo. On the right, there is another figure, which is a league table that figures the relative treatment effects of every combination of intervention 2 by 2. As we've said previously, network meta-analysis also allows an estimation of the ranking of the included intervention. Several methods are available, including the probability of being best. This method gives a probability for each intervention of being ranked first or second or third. And there is also the mean rank and the surface under the cumulative rank curve. However, as you can see on the figure on the right, the forest plot that we've seen before, you see that sometimes there is an overlap in the confidence interval of the relative effects of the treatment being evaluated. This overlap in the confidence interval is sometimes overlooked by some of the methods used to rate the intervention, which is the case for the probability of being best, which is why more appropriate methods such as the mean rank and the SUCRA are recommended. However, whatever the method being used, it is important that authors, when reporting the rank values, also report the treatment relative effect as well as the confidence interval to avoid any spurious conclusion regarding the efficacy of the interventions. Additionally, it is important for authors to grade the certainty of the evidence provided by their network meta-analysis. There are two approaches available, the grade approach and the cinema approach. Both of them rate the certainty of the evidence from a network meta-analysis. Both methods rely on the following domains: the within study bias, the reporting bias, the indirectness, imprecision, heterogeneity, and incoherence. On the right, you can see a figure which is a comparison adjusted funnel plot that is used in network meta-analysis to detect eventually reporting bias and, if present, assess the presence of small study effect. In this figure, you have a league table with a visual representation of the certainty of evidence for every 2x2 comparison between the included intervention. You have a color system here where the green represents the comparison where the certainty of the evidence is high, in blue where the certainty of evidence is moderate, and in yellow where the certainty of the evidence is low. Grading the certainty is important as it enhances the transparency, the reproducibility, and the credibility of the result in the network meta-analysis. So now that I'm done with the methodological points for readers, authors, and reviewers, I'm going to give my place to Dr. Laurence Le Cleach.
Sorry, I just passed a slide you already have seen. So, good morning. I hope you're fine. I'm very happy to have the opportunity to present you the concept of living systematic review and network meta-analysis. My talk will be based mainly, as the one from Robin, mainly on the example of systemic treatment for psoriasis. A better understanding of psoriasis physiopathology leads to a dramatic increase of number of available systemic treatments during the past 2 decades. Only methotrexate, cyclosporine, and phototherapy were available until the beginning of the noughties. Since then, 13 new treatments, biologic, anti-TNF, anti-IL-12/23, anti-IL-17, and anti-IL-23, and small molecules were approved. Given this high number of available treatments, the question for physicians is thus which interventions work best and is best tolerated. To answer this question, we performed a Cochrane systematic review using network meta-analysis method. Criteria for inclusion in the systematic review were all randomized controlled trials assessing in adults with a moderate to severe psoriasis, systemic treatments, conventional, small molecule, and biologic, compared to placebo or between them. Efficacy primary outcome was PASI 90, and safety primary outcome was serious adverse events. In such situation, as Robin already told you, where many trials including some head-to-head drug comparison are available, network meta-analysis is a useful tool to answer the question which treatment work best and are better tolerated. Indeed, conventional meta-analysis compare only 2 interventions and only those evaluated directly in head-to-head trials, so mostly having placebo as comparator. whereas NMA, network meta-analysis, allows evaluation of multiple treatments in a single analysis by combining the direct and indirect evidence. It also allows to rank the intervention in terms of efficacy and safety. This Cochrane review was first published in December 2017. 109 trials were included in systematic review and 74 in the network meta-analysis. However, results of this NMA became quickly out of date. Between 2017 and 2019-20, 31 trials, new trials were published, and including some on 4 new molecules. Yet physicians, of course, need to have a complete and up-to-date synthesis of the evidence to provide optimal care to patients. Issue of out-of-date systematic review is well known. One study found, for example, that 7% of systematic review are any more up-to-date at the time of publication, and 46% of Cochrane review are up-to-date. It is time to change paradigm with a new process called living systematic review. The current model is to update several years after the first publication a systematic review and meta-analysis. This means that often the team in charge of the first review is not available anymore, and the memory of knowledge acquired during the process is lost. And for active fields such as psoriasis, this means also a big new amount of references to manage and heavy workload in one go. Living reviews, systematic reviews, consist in a continually update and incorporate relevant new evidence as it becomes available. In practice, actualization of the search is performed each month, and information are added in the What is New box after selection. And extraction and risk of bias assessment for new included studies are performed as well continuously. This means a small workload each month, manageable for a stable team. And analysis followed by a peer review process are performed every year. Network meta-analysis provides specific challenge in the process. Specific challenge in the process of living systematic review because the network will change when new comparison or new drugs appear. It implies to identify new or withdrawn drugs and adapt your strategy accordingly. And then add to the network new trials, as in figure 2, new trials already in the network, or to add new treatments. That implies to add new nodes, as you can see in the 2 last figure. For the NMA on psoriasis, we started, I'm sorry, it seems that the number are high on the slide. I'm really sorry for that, but I will tell you the numbers. So for this NMA, as I already told you, we started in 2017-78 with 109 included trials assessing pharmacological treatments for chronic plaque psoriasis, and 140 in 2020, 158 in 2021, and there will be 167 in the last update that will be published in March 2020. Logically, including new trials and new molecules leads to change the ranking. These graphs represent the results for the version of 2017 and 2021, the first one and the last one published. On the horizontal axis, you can see the PASI 90, the ranking for the PASI 90, and in the vertical axis, the serious adverse events. Optimal treatments should be characterized by both high efficacy and tolerance and should be in the right upper corner of this graph. Underlying drugs are those for which the level of evidence was considered as high, using cinema, and molecules presented in the same color are the same ranking. Leaving enema could also help to optimize the guideline development process and to update recommendation as soon as the new relevant evidence is available in a process called Living Guidelines. This is the case for the European Living Guideline on psoriasis, which is based on the Cochrane NMA and updated at each new version of the Cochrane. Living systematic review is an emerging process. First living systematic review was published in Cochrane Library in 2017. The one on systemic review on psoriasis was the first NMA published as a living in 2020. And on PubMed, as you can see, one can find one living systematic review in 2015, 10 in 2019, and a huge increase in 2021 with 100, more than 100. This increase is especially due to a proliferation of living systematic review on COVID. Many, unfortunately, many publications on COVID are probably not relevant and not really useful. However, some are absolutely needed and very important. As the one from the WHO and the Cochrane called COVID NMA, I let you have a look on the dedicated website, which is interactive and contains all information on terminated and ongoing trials for prevention and treatment of COVID. It's a very, very big work. Little want to say that several tools using artificial intelligence are available to select randomized control trial from initial reference list or to assess risk of bias using data mining. These tools allow us to save time and are constantly improved. So we are able, since 2020, to provide a regularly update ranking of all available treatments for chronic psoriasis in terms of efficacy and safety in the short term. It will be ideal to provide now such ranking for specific population. Which treatment is the most efficient and safe in the short term for a woman, a man, people with low or high weight, people after anti-TNF or other failure or in first line, having or not arthritis, and so on. Unfortunately, in publications, these data are lacking or not presented in the appropriate format to be synthesized in the network meta-analysis. To answer this question, the relevant method is network meta-analysis on individual patients' data that can provide the raw data of all RCTs. These data exist, are somewhere in computers, but still difficult to obtain. We hope that initiatives to promote data sharing and transparency will make it possible in the next future. Other questions remain and should be answered, and Professor Sbidian will develop this point in his talk. To end, I want to warmly thank all the members of the team of the Cochrane Enema on psoriasis and also the team of Cochrane Skin Group, and they all have done a huge work. Thank you very much.
So thank you, both of you. A lot of information in a few minutes, but this is all the more important as such methodology is hard to understand, and we hope it will help to read some network meta-analyses, some published network meta-analyses. So let's move to the limits of network meta-analysis for psoriasis, and more generally to chronic inflammatory disorder. We've just seen that using published data and specific methodology, we were able to identify treatment option for psoriasis and then assess benefit and risk for each drug. And lastly, to provide a ranking between them. However, this evidence can be extrapolated to a selected trial population with a short-term assessment. And for chronic inflammatory disease, including psoriasis, we need long-term efficacy and safety outcomes. Since the development of biologicals for psoriasis, the pharmaceutical industries have designed more and more extension phase trial. Thus, we first get results from the induction phase, less than 24 weeks, usually from 12 to 16 weeks for psoriasis, and then obtain result in terms of efficacy and safety at 1, 2, 3, 5 years after the first randomization. In this context, Sawyer and collaborators perform a systematic review on the network meta-analysis of efficacy outcomes measured at 1 year, and they identified 24 studies. However, they could not pull the results as the design of this extension phase were very different. First, they identified 5 trials which randomized participants in 2 different groups from week 0 to week 52. Then they identified 14 trials with placebo crossover and also observational maintenance phase for the intervention group, so without any comparators. And lastly, they identified 5 trials with which re-randomize only good responder participants from the induction phase. So due to the low number of identified studies and also to the different design, no strong conclusion was available. So using the data from the Cochrane review we've just talked, we identified 120 trials assessing biological treatments. Among them, 65 trials had a follow-up over 26 weeks. You can see a Sankey figure, a Sankey graph just here, summarizing the design of the extension phase of the 65 trials. You can see that it is a mess in terms of selected population, in terms of design, interventions, controls, and outcomes. For example, some extension phase include only participants from the first induction trials, whereas other extension phase pool replicate trials. Then some include all the initial participants, other include only good responder participants, but good responder participant definition is not the same between each trials, PASI 50, PASI 75, or other criteria. Intervention are also quite different, using the same dosage from the induction phase or withdraw the treatment, many different controls and outcomes. So this Sankey graph highlights that this is impossible to validate meta-analyses to assess both efficacy and safety results at long term, and we need harmonization on long-term trials. So to get long-term efficacy and safety outcome, we need other data sources or other methodology. For example, in 2015, using the data from the UK National Cohort for Patients with Psoriasis, Warren and collaborators used for the first time, I think, the survival rate as an efficacy and safety outcome. So the survival rate or treatment persistence is the time interval between treatment initiation and discontinuations. And this seems to be a good proxy of effectiveness and safety, as a treatment perceived as being ineffective will not be continued, as well as a poorly tolerated treatment. So in this figure, this is an example of French health administrative data where patients with psoriasis were selected from January 2015 to December 2020. And around close to 17,000 patients initiated a biological agent. Patients were divided into three groups, anti-IL-17 groups. I think this is the red curve. Anti-IL-12-30 group with the blue curve. And the last group was TNF inhibitors group with the green curve. So you can see that at 3 years, the persistence, the survival rate was very low, around 40% of participants maintain their first biologic treatment. And you can also see that IL-17 and IL-12-23 inhibitors had a higher persistent rate compared with TNF inhibitors groups. By definition, such observational studies are not trials and are not, so baseline characteristics between groups, social demographic characteristics, comorbidities, severity of the disease could be different between them. So you need to take into account such differences using adjustment or weighted ponderation, for example, to be sure that the difference you see between the group is related to the treatment and not to the baseline characteristics. However, the certainty of evidence is lower compared with RCTs, as this is difficult, impossible to take into account all the potential confounders. Nevertheless, such studies are very interesting in the daily practice. And as an example, the Corona Psoriasis Registry, which is a US registry, recently showed that there is some differences in terms of survival rate between biological agents. They identify more than 1,600 patients with psoriasis divided in 3 groups: ixekizumab, other IL-17, and TNF inhibitors. They take into account the differences between groups using adjusted Cox model, and they show that ixekizumab had a better persistence compared with other IL-17 and compared with TNF inhibitors. Of course, several observational studies saying the same, showing the same result are needing due to such design and the risk of extra potential confounders. So, second limit of network meta-analysis is a selected population. Indeed, more and more non-inclusion criteria are requested over time. And finally, patients including in RCT are not patients treated in daily practice. For example, in the UK cohort, bad beer cohort, the proportion of patients registered in the cohort who will not be eligible for a randomized controlled trial is close to 50%, and this is a huge proportion. So once again, we need other methodology and other data sources to get safety and efficacy outcome in an unselected population. This is all the more important because social demographics and clinical characteristics were associated with reduced odds of achieving PASI 90 improvement, such as female sex, unemployment, smoker, height weight participants, and so on. So survival studies are usually performed on registry or health insurance database with data from an unselected population and a large population. So last point is the adverse effect of interest. In the Cochrane review, we did not show differences between the number of serious adverse events in the intervention group compared with the placebo. So several hypotheses can be discussed to explain this absence of difference. For example, a highly selected population in RCT. We've just discussed this point. So patients with less comorbidities, so with a lower risk to get a serious adverse effect. Maybe RCTs are underpowered to detect rare events, and some serious adverse events may also occur over the long term. Another hypothesis is a problem of reporting of this serious adverse event, and using the Cochrane review, we identified 51 trials with close to 25 participants receiving a biological agent or a placebo. So we assess the number of serious adverse events of each group, both intervention and placebo. And after excluding cases of psoriasis worsening in the two groups, in the intervention and in the placebo groups, we show that the risk of serious adverse events was higher in the biological treatment group compared with placebo. And this was especially the case for serious infection. So once again, a need for other data sources and other methodology. And a last example, using the French health insurance database. So we identified more than 44,000 patients initiated a first biological treatment, and we follow them until a serious infection or until the end of the study, or until death, whatever came first. And during the follow-up, we identified 1,600 infections, mainly gastrointestinal, skin, pulmonary, and urinary infections. And taking into account the differences between the groups, we show that adalimumab and infliximab had a higher risk of developing a serious infection compared with etanercept, whereas the risk of infection was lower for the patients using ustekinumab. We did not show any difference between etanercept and IL-17 or IL-23 inhibitors. So, in one end, RCT have a better quality of evidence because they are designed to compare efficacy and safety between the different interventions. And on the other hand, observational studies can provide safety and efficacy data in daily practice. That is to say that they include unselected population, older patients, patients with comorbidities, and allows also a longer follow-up with a larger sample size. This allows also to increase the capacity to detect long-term outcomes and rare adverse events. So with the team, we propose a new Cochrane review, systematic review on network meta-analysis dedicated to serious adverse events associated with systemic treatment for psoriasis, using both observational studies and randomized controlled trials. So much work ahead, but we hope very important and interesting results, which will be combined with the efficacy result from the living Cochrane. So maybe, Robin, to conclude with the take-home message.
Sure. So to conclude this presentation, we've seen a lot of methodological points and consideration for network meta-analysis. So what we've seen is that this method is complex and can be challenging, but as we've seen, there are many available resources such as the Prisma and EMA statement, GRADE, Cinema, or the Cochrane handbook that can help authors conducting network meta-analysis and help them using the most up-to-date tools to perform the best network meta-analysis possible, which can have a high level of confidence if they are well conducted. This needs, of course, the collaborative work of clinicians, methodologists, and statisticians that must have a good knowledge of systematic reviews, network meta-analysis, but also the health domain in which they are interested. Living network meta-analysis is the best model for an active therapeutic field, just as Dr. Laurence Le Cleach told you, when there are a lot of new treatments that are promoted every month, every year, which can keep the clinician and the patients up to date as for the treatment that are the most effective and the most tolerated. Like Professor Sbidian told you, there is a usefulness of combination data from RCTs and observational studies to overcome the limit from both types of studies. And the next step will be for network meta-analysis to use individual patient data, but for that there's a need for transparency and sharing between the different teams and the ones conducting randomized controlled trials or observational studies. Thank you very much for your attention, and now we will be glad to take any of your questions.
Hi, so we have one question for the moment. Will be to have the slides, to have the reference. I think that the different presentation will be available after the talk. And thank you for the different congratulations. Perhaps we can, waiting for new question, discuss a little bit. I think that, Robin, could you perhaps tell us in the results of a network meta-analysis, when you have results in an abstract, we know that there is many network meta-analysis on this field of psoriasis, and how are different the results in the different abstracts, and regarding specifically the warning you told us about the interval of confidence between the different comparison and in the ranking. Thank you.
Yes, exactly. So, as Laurence Le Cleach just said, in psoriasis, since there are a lot of new treatments coming out every year, and also a lot of randomized controlled trials that are performed to assess the efficacy and safety of those treatments, there are also a lot of systematic review with network meta-analysis evaluating the efficacy and safety of those treatments. There are a lot of them that are being published, and they are evaluating the same treatment, usually with the same research question, and there are some overlaps between those different studies that are evaluating the same treatments. When we look at all the studies, what we find, and especially when we look at the abstract, is that there are some differences, some discrepancies between the treatment reported as being the most effective or the safest. And this is a bit preoccupying, since when we look at the Cochrane systematic review, which use methods that are validated and that are supposed to be the most robust and valid for network meta-analysis, when we look at the result, there is not one single treatment that is deemed the most effective or the safest, and usually it's a group of treatment, because as we've seen in some previous slides, there is an overlap between the confidence interval of the relative treatment effects that are estimated in the network meta-analysis. And this overlap in confidence interval can be sometimes obscured by the value of the ranking alone. And we've seen that in some abstract, there are a reporting of only the treatments that are deemed the best given one value of the ranking estimation. And this completely put aside the overlap in efficacy that those treatments can have, and the uncertainty that surrounds the estimation in network meta-analysis. And of course, when we look at the recommendation in the Cochrane handbook or different scientific sources, the recommendations are clear that when you rank the different treatment, you have to take into consideration those overlaps, because they often exist. And readers should be really careful when reading only the abstract, because it can make them believe that you can show that one treatment is the best, the most effective, the safest, when in reality, when you look deeper in some of the manuscript, that there are still some overlaps that have not been reported in the abstract. So it's maybe a problem of reporting, but this is really essential to keep in mind, obviously.
Yeah, this is a very important point. You're totally right. So we have a question: do we have methodological guidelines specifically for long-term network meta-analysis? So I don't think so. We have some guidelines for network meta-analysis using RCTs, using also observational studies. It's quite difficult. It's more challenging to perform network meta-analysis using observational studies, because once again, the certainty of evidence is lower compared with RCTs. But I don't think that there is a specific guideline for long-term network meta-analysis. And the second question, is there a way to critically appraise published network meta-analysis when we do not have the individual data. I'm not sure that this is real associated. Individual data allow subgroup analysis and assessing efficacy and safety for some patient with such characteristics, and network meta-analysis using aggregate data provide yes more generally results for a population.
Yes, and even though if I don't think there is a specific tool to critically appraise network meta-analysis. There are some tools that exist, but the one that is used, for example, for classical meta-analysis, AMSTAR2, for example, they don't take into consideration the fact that you have aggregated data or individual patient data. It's more the method used, the way the systematic review was conducted, the way you addressed heterogeneity, the way you perform subgroup analysis or meta-regression when you have heterogeneity. But you can have a good degree of certainty, or even though you have aggregated data, I think it doesn't take into it doesn't come into consideration when critically evaluating NMA.
There is an initiative ongoing to build a tool to appraise specifically network meta-analysis, but I think that it will not be available before at least 2 years. I'm not sure. We have new question. How can one learn more things about performing network meta-analysis? Are you aware of any courses? Is a statistician always need? So yes, absolutely, a statistician is absolutely needed, because there is some tool already registered to perform this on Stata or AIR, but without high skill in statistics, it's not possible to use it properly. And there is courses regularly. There is a webinar to learn to perform a network meta-analysis, and notably in the Cochrane, there is through the Cochrane collaboration, there is regularly some. And another question, Phyllis, hi Phyllis. In the NMA with IPD, are you only incorporating RCT data or so-called data? I think that if we succeed in doing one with and get the results of randomized control trial, we'll be very happy, and it will be a very, very, very important work to deal with all these data. So to begin, I think that we will start with RCTs.
And the second question was, could you explain the differences between the result of NMA 2017 and 2020 in terms of ranking? Or it's quite difficult because there were new treatments between the two updates, and it's some intervention at the beginning had only one trial, and so there is imprecision. It was the one of the limits Dr. Guelimi showed us, and so maybe he could explain a little bit differences, but at the end, I don't remember, except for new drugs, that there were big differences in terms of ranking. And I also saw network meta-analysis. Oh, no, it's not a question. Yes, could be a promising method for data synthesis, of course, but totally right.
Okay, so I think that we can close the session now. And thank you.
Thank you for your participation. Thank you.
Thank you.
So, on behalf of the EADV, we would like to say a special thank you to all of our speakers today. Thank you very much. And we would like to say a special thank you also to our audience who you gave us some great questions. Thank you for joining us, sharing your thoughts, great questions. And you've also given a lot of positive feedback. We know you like the subject. So we have some exciting announcements for you coming up. You are invited to join us in Ljubljana, Slovenia, for EADV's 17th Spring Symposium from the 12th through the 14th of May. Also to let you know, face-to-face courses are back. Specialists, residents, and now nurses all have the possibility to attend EADV organized courses. We're looking forward to meeting you in some of the most beautiful cities in Europe. To see what's coming up next, go to eadv.org and check under face-to-face education. On the 2nd of February, you can join us for our next webcast, Frequent Situations on Tattoos and Tattoo Removal. And at any time, you can check out the Dermatology Podcast, EADV's official podcast, available on all major podcast platforms, including Apple and Spotify. Don't forget to follow or subscribe. Thank you again for joining us, and have a pleasant day.